We should start now. Adit?
Yes, ma'am.
Yeah, you can start
Yeah.
now. Dr. Gaurav is there?
Yes, ma'am. Sorry.
Okay.
So good evening, all respected seniors.
Sorry for
And
interruption. Kishore, are we live now?
yes, ma'am, we are live.
Okay, take it.
So good evening, respected seniors and my dear colleagues. Welcome on the platform Onco Ocean. As we all know, currently we are moving forward discussing our present module, carcinoma breast. Today's topic will be dedicated to role of rehabilitation in the management of carcinoma breast. As we all know, rehabilitation plays an important role in multimodality management of the carcinoma breast. So for today's session, I feel honored to welcome our chairperson, Dr. Gaurav Goswami. Dr. Gaurav sir is a senior consultant in radiation oncology department at Apex Hospital, Varanasi. Sir has completed his MD radiotherapy in 2016, and after that he's completed a fellowship in clinical oncology from Tata Memorial Center, Kolkata. He has over 10 years experience in field of oncology, has special interest in breast and gynecological malignancies, and is well versed with precision techniques like IGRT, VMAT, and SBRT. Welcome, sir.
Good evening, everybody. It's really a great opportunity to discuss this topic. And I think that Dr. Dibyendu needs a very short, brief introduction. And he's one of the only, probably the only person in this part of the country who deals with the kind of rehab facilities which we have been providing. So Dr. Dibyendu has been with us for almost 8 to 9 years. And the main objective of Dr. Dibyendu is to take care of all the surgery, the cancer chemotherapy, and the radiotherapy kind of side effects, which we have been facing for a very long time. And he's a very adept person. He has got extensive knowledge, extensive experience, and he's been managing several hundreds, probably thousands of patients. So it's really a great opportunity for all the students, PVTs, and all our colleagues to gain an insight regarding to what this onco rehabilitation is all about. Because as far as we know, this branch is still in its infancy, and we hope that Dr. Dibyendu will be taking this branch to newer heights. So over to you, Dr. Dibyendu, and we hope we have a very great session and very enlightening session.
Welcome, Dr. Dibyendu, sir. I would like to I like request you to share your screen, sir.
Yeah, sure.
Aditi, your voice is very low.
Okay, ma'am. I'll try to speak a bit
I don't know
louder.
why. When you speak, the voice is not very. Voice is clear, but the volume is low.
Okay, ma'am. I'll try to speak a bit louder. Probably some issue with the microphone.
Okay.
Can you see my screen?
Just a minute, sir. Yes, sir.
Yes, it is visible.
Good evening, everyone. Thank you, Dr. Gaurav, for a nice introduction. Thank you, Dr. Aditya. And I'm good evening to everyone. And thank you for giving me the opportunity to speak with such an esteemed group of clinicians today. Before I begin, I want to acknowledge the immense work that each one of you does in the fight against the breast cancer, from diagnosis to treatment and beyond. Your dedication saves lives and gives hope every day. Today, I like to talk about a part of the journey which often remains under-recognized but is profoundly impactful, that is the rehabilitation. And before I start, I just want to be little clear that this is not a critique of our current practice, but rather a call to widen the lens through which we view the survivorship and the patient quality of life. My intention is to complement the excellence of oncology care with insights into how targeted rehabilitation can further empower our patients physically, emotionally, functionally, throughout their recovery and the survivorship. So when a patient hear the word cancer, first question come to their mind that why it's to me and why it happened to me and how it's going to affect my life, my family life. So why this matter? It's this topic is so much important today because over 2.3 million new breast cancer cases have been diagnosed annually. With the modern treatment and everything, survivorship is getting more and more, more and more. So our focus has to be on the quality of life. There are, like with the modern treatment also, there are high prevalence of post-treatment impairments are coming. So here the rehabilitation plays an important part in the cancer care, which trying to address the physical, emotional, and social well-being of the patient so that they can have their make their life more purposeful and they can live with dignity. This is the main purpose. So we have to understand what is this cancer rehabilitation. Cancer rehabilitation is a multidisciplinary approach to restore function, reduce the disability, and improve the quality life of the cancer survivor. It involves the surgical oncologist, medical oncologist, radiation oncologist, onco-rehabilitation physiotherapist, occupational therapist, psychologist, speech swallow therapist, and dietitian. This rehabilitation is tailored to individual needs across their cancer treatment. So what is the ultimate goal of the rehabilitation for the breast cancer patient? It is the main goal to improve the shoulder and arm function. It can prevent the shoulder drop. It can improve or prevent the seroma also. It can reduce the pain. It can manage the chemo-induced peripheral neuropathy. It can manage the oral mucositis. It can manage axillary wave syndrome. It can manage the cancer-related fatigue. It can manage the hair fall as well. It can enhance the psychological well-being, and ultimately it helps the patient to support to return their activity of daily living. So what are the phases of rehabilitation? It's not like that ki just rehabilitation has to be start after the treatment. Actually, if we take it in a proper way, it should be start before the treatment itself. So we call it a prehabilitation phase. Like when the patient is coming to a doctor, it may be surgical oncologist, it may be radiation oncologist, or it may be medical oncologist. We should make the patient understand the what is going to happen to you, how it's going to change your physical thing, and how it's going to affect your body. And we should motivate the patient that what kind of posture he should practice and what kind of exercises she should start maybe before the surgery itself, and what she should continue after the surgery. Then it comes the phase, this acute rehabilitation. This acute rehabilitation starts during the hospital stay. Like just after the surgery, patient can start their rehabilitation. This is very much important. And then it's come the sub-acute rehabilitation. So it's just after the surgery or during an radiation and chemotherapy. And the long-term survivorship care comes after the treatment. And then it's come the palliative care, which is the end of life rehabilitation. So what are the common functional impairments we get in the breast cancer patient? Shoulder stiffness and reduced range of motion, post-mastectomy pain syndrome, lymphedema, seroma, chemo-induced peripheral neuropathies, fatigue, cognitive impairment, and psychological distress. So shoulder stiffness, why it happens? The surgical trauma mainly for mastectomy, lumpectomy, and the axillary dissection causes some kind of nerve damage. So ultimately it hampers the shoulder range of motion, especially abduction get lot of trouble. Radiation-induced fibrosis can also happen. Scar tissue and capsular contracture can happen. Protective posture, and there is always a fear of movement come into the mind, and pain and muscle girding. This all can cause the shoulder range of motion restriction. So what is the rehabilitation goal of this kind of trouble? To restore the pain-free shoulder range of motion, to prevent the adhesive capsulitis, to improve the posture and scapular mechanics, promote confidence in the movement, and facilitate the activity of daily living. So what is how we will start the rehabilitation? So question come, like surgery has been done, mastectomy has been done. So after how much time we can start the arm movement? Generally, with the advice of and with the permission of the surgical oncologist, we can start the movement immediately within 24 or 48 hours of surgery. If there is no kind of drain or any kind of flap complications are there, then we can start with the pendulum exercises. We can do wall crawling. And if the patient is having a little bit more trouble, so we can do soft tissue mobilization. We can go for scar tissue massage. We can do joint mobilization. We can do even pectoralis stretch. We can do shoulder flexion, abduction, and external rotation. Postural muscle strengthening we can do. Ergonomic training we can do. We can do the protective posture. Patient is always having a protective posture they going to have. So we can prevent that. We can advise thoracic extension exercise. We can ask the patient for the task-specific activities. And slowly we can increase the range of the exercises with the days. So then it comes the post-mastectomy pain syndrome. Patient always complain a little bit of hypersensitivity in the chest wall or in the shoulder, because in the surgery, the nerve gets affected. So patient always complain a kind of pain. Sometimes it can be a phantom pain also. So here the rehabilitation can play some role. Desensitization therapy is very helpful in that. So slowly, gradedly, we have to increase the touch sensation to the patient, because in this kind of problem, whenever you touch the chest wall, or in case of lumpectomy, whenever you are touching the breast, they are complain little bit of pain or some hypersensitivity. So here we gradually, with the graded touch therapy, we can desensitize those places. And in some cases, we can do, in post-mastectomy pain syndrome, we can do myofascial release and scar mobilization, because this myofascial release can really relax those scars. Ultimately, when the patient, why they are having this pain? Because for the scar, they are unable to do their movement properly. They are complaining of pain. So here next we can do neurodynamic exercises. These are the nerve gliding techniques, which would also ultimately help to reduce the pain. There are some pain modulation techniques like photobiomodulation, cryotherapy, transcutaneous electrical nerve stimulation also we can use. We can motivate the patient for the thoracic mobility, and the scapular alignment we can suggest to the patient. Now question comes, how this PBM helps in this post-mastectomy pain syndrome. Actually, this post-mastectomy pain syndrome is nothing. It's just a neuropathic pain. So this is not always only can be cured with the medication. Along with the medication, if we can apply this photobiomodulation is nothing. It's a class 3B laser. So ultimately, it promotes the nerve regeneration. It reduces the inflammation and modify the pain pathways. So ultimately, it helps to reduce the pain. So mechanism, here, if you can ask for the mechanism for the photobiomodulation, here we typically use the near infrared light, and its range is typically from 600 to 1000 nanometers. So what happens when we apply this laser? So this laser, it's been absorbed by the cytochrome C oxidase in the mitochondria. It ultimately increases the ATP production, and it reduces the oxidative stress inside the cellular cell. It downgrades the inflammatory cytokines. It improves the nerve healing and demyelination, and it modulates the nociceptor sensitivity. Next, it comes the axillary web syndrome. Axillary web syndrome is also known as a cording complication followed by the breast surgery, especially after the axillary lymph dissection and sometime after the sentinel lymph node biopsy. It's a painful condition. It's a rope-like structure from the chest wall. Sometimes it extend up to the arm, and so they have restrict the movement of the shoulder range, especially it restrict the abduction, and this is a very painful condition. So what causes this axillary web syndrome? This surgical trauma is damage to the lymphatic and venous structure, fibrosis, inflammatory response like post-surgical healing causes excessive deposition of and impaired lymph flow leads to thickening of the lymphatic cords. So what are the risk factors? We can, as we discussed, the axillary lymph node dissection, post-surgical radiation therapy, patients who are not very habituated with their physical activity and in the fear of what is going to happen, they don't do much of physical activity, and who are a little bit obese, who people have the upper side of BMI, they can have this problem more. So what are these clinical symptoms of this axillary web syndrome? It's a rope-like band running from the armpit down to the forearm, and there can be the pain and tightness in the shoulder abduction and arm elevation also in the bad scenario. It restricts the joint range of motion. Ultimately, sometimes it can cause the lymphedema even. So how we will diagnose? You can see it's a visible, palpable cord in the axillary region. So we can just ask the patient to abduct their arm, and we can just palpate. And in the when it's very much high, this cord is very tight, that is visibly palpable. And when it's not that much high, so we can do a little bit of one ultrasound we can do, so that the fibrotic lymphatic system we can see, and we can plan our thing like axillary web syndrome. So what are the management comes here? So general shoulder exercises. We have to tell the patient, if patient is able to do it by their own, they can do it. And if they are unable to do that, we have to help them. And gradually we have to increase the range. We can do flexion stretching. We can tell them to do wall crawling exercises, scapular mobilization we can also do. Here also we can do the myofascial release and soft tissue mobilization. And gradually, when the range is getting a little bit better and the pain is a little bit less, that time we can do the stretching gradually. So here also PBM can play the role. It ultimately, PBM, how it's going to help? It reduces the inflammation and fibrosis. It improves the lymphatic drainage. It relieves the pain and enhance the tissue elasticity. Here also, if you want to know the exact dose of the photobiomodulation, we have to use the 4 to 6 joule per centimeter square over the axilla of the affected cord, and frequency can be 3 to 5 days a week. And if you want to see that how we use that, so patient have to abduct their arm, and this is the laser probe. So what we can do, we can just keep in exactly on the band of where the pain is happening. Then we have to just switch it on, and we have to fix the dose, and this way They have to take the treatment for 5 minutes every single day. And ultimately, you can see a lot of changes in their pain. Along with the photobiomodulation, if we want to improve regarding more, so this is the cryotherapy we can also use in this. This also after the photobiomodulation, we can use this cryotherapy. This will also ultimately reduce the pain. So already I have discussed this, how to apply this PBM. So I'm not going to discuss this along with the exercises, along with the stretching. Not only PBM will help, not only cryotherapy is going to help, along with the graded exercises, stretching, manual mobilization, soft tissue mobilization, scapular stabilization. If we apply this photobiomodulation in cryotherapy, it is going to help the patient quickly. Then the most debilitating problem comes in, that is the lymphedema. Lymphedema is nothing, it's a chronic swelling of the arm due to the lymphatic system dysfunction. It can affect not only the arm, it even some, in the worst cases, it can affect the breast even. So gradually, if the lymphedema stays for a very long time, it can slowly increase the pain, it can increase the heaviness of the arm, and if it stays for a very long time, there is a chance of infection also happens. So the gold standard of the lymphedema is complete decongestive therapy. So complete decongestive therapy have some steps to do this treatment. First is very important, that is skin care. Like generally when a patient is having this lymphedema, generally their lymph volume is getting increased. Due to that, the patient have complaint of dry skin. So that time we have to advise the patient that they should apply moisturizer to their arm. General mistake which happens, patient generally take any kind of moisturizer and they apply it from down to up. That we have to ask the patient that during the application of this moisturizer, you have to do this application from upper side to downward side because of the follicle. Like if we apply the lotion moisturizer from down to up, it can go inside your follicle and it can happen there. It can, patient can be have folliculitis problem. This is most important. Then the decongestive exercises, like before doing, like we have to think that patient have already gone through the axillary dissection, so they have the not they don't have the normal lymphatic drainage. So before starting any kind of treatment, we have to activate the remaining lymph node which they have in their axillary region. So we have to do that decongestive exercises. Then we have to do manual lymphatic drainage. If the patient is having this trouble for a very long time, suppose the lymphedema is fibrosed, so that time only with the IPC, like intermittent pneumatic compression, is not going to help. Before that, we have to do some drainage with manually, so that where the patient require more compression, we can have to apply more pressure, and where it's not that much required, we can apply less pressure. Then we have to use the multi-layered lymphedema bandaging. This comes in the phase 1. And when the patient have going to complete their treatment, that time we have to prescribe the pressure garments to the patient. Here also photobiomodulation play a very crucial role in the lymphedema management. Like it stimulates the formation of the lymphatic channels. It reduces the fibrosis, tissue fibrosis and inflammation. It increases the macrophage activity and fluid resorption, decreases the oxidative stress in the lymphatic tissues. What happens before the lymphatic drainage or any kind of intermittent pneumatic compression, or before doing the bandages, if we apply this photobiomodulation to the axillary region, so it can increases this cellular activity so that the lymphatic flow will be better. And after doing photobiomodulation, if we go for this complete decongestive therapy, is going to help much more faster. So ultimately, this is the like combined benefits of this CDT, like combined decongestive therapy and photobiomodulation, is going to greater and faster volume reduction. There will be reduction in the fibrosis in chronic cases. It improves the tissue softness and limb contour, and ultimately it improves the quality of the life. So now the question comes in, like which kind of bandage we have to use. Generally speaking, very honestly, like most of the in most practices, we suggest the patient you can do bandaging with a crepe bandage. But if you take the proper suggestion, the crepe bandage is not that beneficial because there are some particular reason. Because short stretch bandage we use this in this combined decongestive therapy, because short stretch bandage their working pressure is much and the resting pressure is very low. Like when are you not moving or you are not doing any kind of activity, their pressure is very less. And when wearing those bandages, when you are doing your activity of daily living and you are moving your arm, you are doing whatever activity you are doing, that time the pressure bandage gives you more and more pressure, which is ultimately required. Most importantly, during the active phase of the treatment, like the pressure garment has to be wear, no, sorry, like the bandages has to wear for 15 to 16 hours. And we suggest the patient you should wear this bandage during the night time. But if we wear this any kind of suggest any kind of long stretch bandage or crepe bandages to the patient, it is not recommended to keep those bandages in the night, because in the night patients are not doing any kind of activity, and when are doing applying the bandage, when you stretch it, you go very long. So ultimately it gives a lot of more pressure in the night, which is not recommended. Now the question comes, like when the patient have long standing lymphedema, can pressure garment really can reduce the lymphedema? The question will be no, because like pressure garment is comes in when the patient have already completed the treatment. Because pressure garment like bandage, we can see wherever the pressure we have to apply in which way. Like suppose in the elbow region, we have more lymphedema. So that time we have to apply more pressure into the into the elbow region. But in pressure garment, you cannot really do that. So better not to suggest pressure garment in the active phases of the treatment. Active phases of treatment, please suggest for the combined decongestive therapy. And then when the treatment is over, that time you suggest for the pressure garment. Now question again comes in, like pressure garment, which kind of pressure garment? That is very, very important. Most of the pressure garment which is available in the market, it finishes here. It's not covered up to the like the nail bed. It ultimately cover up to this. So what ultimately happened? Patient complain edema in this portion. They in the phalanges they complain, and in most of the pressure garment here it finishes in the arm, and they have a tight band here. They develop lymphedema very quickly. So this kind of pressure garment is very much suggested, like where in the arm you will have no pressure. It will be very much loose. It will be open. So it's like a flower. It should be like this, and it should be conical. Most of the pressure should be on your palmar area, and the pressure slowly will reduce. Like if the pressure garment should be in the two like divided portion. One is gloves that you have to wear in the, like when are you doing any kind of activity, so that you can remove the gloves, and rest of the arm should be this kind of pressure garment should be wear. Where here there will be no elastic will be there. That is very much important. Now, like for the lymphedema, we have to ask the patient not to measure any kind of BP. in the affected side hand, not to do any kind of blood test in the affected arm. We should advise the patient not to wear any kind of glass bangles in the affected side. We should ask the patient not to wear any kind of ring in the finger. We have to advise not to use any kind of nail paint in the affected arm. And one should not touch the extreme temperature, like extreme hot or extreme cold, they have to avoid. Now, this question comes, why these things are avoided? Like already our lymphatic system is like compromised. And in these bandages and all this pressure garment, their maximum pressure is 30 to 40 mmHg. But when you do this BP and all, so their pressure go very high. So ultimately, it may cause more damage to your lymphatic system. Any kind of little bit of blood puncture for any kind of test can cause infection to your arm. And glass bangles and all, glass bangles can break anytime, so it can it can injure your arm. And why not ring? Because ring always become very tight in your ring. Like this ring, if I want to take it out, it will not come out. So ultimately, it will compress your lymphatic channels. And same with the extreme temperature. Like if we touch any kind of extreme hot or extreme cold, that will also ultimately affect your lymphatic system. Now this problem comes in this seroma. This is also a problem for the patients after the surgery. They kind of like complain about a little bit of pouch thing in the armpit. So they complain about pain, they complain about heaviness. So that time also rehabilitation plays a very important role. Like first of all, we have to suggest the patient for the proper postural care we have to suggest so that the patient doesn't develop this. Generally, after the surgery, we should ask the patient not to turn on the affected side, and they should either they lie down straight or they should turn on the opposite side of the surgery. And if they have like already developed this kind of seroma, so what we can do? We can do this compression garment. Compression garment we can do in two forms. Like the patient, if it's very acute, just they have developed this just after the surgery, that time pressure garment we cannot suggest. We can do this short stretch bandage according to their capability and according to the surgeon's opinion. We have to apply those bandages, and this really helps to reduce the lymphedema, the seroma very quickly. And if any patient develop this seroma like few days after the surgery, like when the patient is getting discharged from the hospital, so that time we can do some auxiliary padding, or there's some kind of pressure garment brazier comes in. So that also we can suggest to the patient. Proper limb positioning is very, very important just after surgery. Generally, what happens, patient doesn't keep any kind of stabilizer or any rest behind their arm. So that ultimately leads to seroma. So here also photobiomodulation can play a role. It actually promotes the wound healing very fast. It increases the fibroblast activity in the cellular cell, and it modulates the pro-inflammatory cytokines and reduce the tissue damage, and it decreases the localized inflammation and the seroma cavity, and it ultimately decreases the pain also. Ultimately, patient get a little bit of relief. So this way we have to apply you can see the patient have already developed some fibrosis in the, so what we are doing, and she is complaining of the pain in the axillary region. So in this way, we apply photobiomodulation, and then we do this myofascial release to give some relief to the patient. Now the most discussed problem comes in, that is chemo-induced peripheral neuropathies. As we all know that in case of breast surgeries, like chemotherapy plays a very crucial role, but most of the patients complain of numbness or tingling in their fingers or into their feet. They have a complaint of burning or shooting pain. They have an increased sensitivity to touch or temperature. They have muscle weakness. They have problem of balance and coordination. They have problem in their fine motor skills. And in some severe cases, they can have the fall also. So why breast cancer patient at high risk of this CIPN? As you all know, taxanes play a very like paclitaxel and docetaxel plays a very crucial role in the breast cancer treatment. So it stabilizes the microtubules, which is a very important like play important role for the axonal transport. And by when the patient is having this chemotherapy, this ultimately hampers of this axonal transport. So patient complain of this like neuropathies and all. Paclitaxel is more neurotoxic than the docetaxel, and they have a they cause a dying type of neuropathy. Dying type of neuropathy, it starts distally and ultimately it goes proximal towards the proximal side. They complain of this. First week they can complain we have a pin rolling sensation in our fingertips. Then slowly they will next week they will say we have it in the palm. Then slowly, gradually their problem go upper side. So like how we be going to assess this CIPN? It's like in the baseline, we have to ask that patient have any kind of history of diabetes or they have a like alcohol use they go for or any before the chemotherapy they have any kind of pin rolling sensation in their hand or they have any kind of history of fall or any fine motor disability they have or they have any kind of muscle weakness or fatigue in the limbs. This have to be asked before the chemotherapy itself. So it's better to understand whether it's happening only for the chemotherapy or already they have any kind of this kind of problem beforehand. During the chemotherapy, we can do the assessment weekly or bi-weekly. So we have to ask like, are you feeling any kind of new tingling or burnness, tingling sensation or burning sensation in your hand, or you have any kind of increased sensitivity in touch, heat or cold, or are you suffering from any kind of difficulty in walking, and are you suffering from any kind of trouble in their activity of daily living, like are you not able to grasp your spoon or are you not able to do your combing or any kind of fall, or are you feeling that I may fall? Or and we have to ask the one more thing very important, is it affecting your sleep or mood? These are things are very like important. This two scale we have to use to assess their CIPN, and this like neuropathy score is also there. That is, we have to ask many questions to the patient. These are the questions we have to ask. The scale typically includes the self-reported like numbness, tingling, pain, weakness. This patient will only tell you, and accordingly, like sensory symptoms, we have to ask like how it's going to affect your life over the past week. How often have you experienced this numbness over the past week? How often have you experienced, like how many times you are suffering from this numbing or numbness or tingling? How often have you experienced the pain or discomfort? And how often it's going to, this pain is going, you giving burning pain or shooting pain, how it's going to. So question will be this, like this, all the options they have to tick all this thing, and ultimately the motor symptoms are also this, and ultimately this question we have to ask to the patient, and accordingly we have to assess how much severity they have for their CIPN. So like the CIPN also impact on their quality of life also. So over the past week, how much has your peripheral neuropathy affected your ability to carry out your activity of daily living, and how it's affecting your emotional well-being or mood? This also we have to ask, and accordingly we have to grade. Photobiomodulation and cryotherapy play a very crucial role in this CIPN. It play a very crucial role. So what are the mechanism of action? Before going to discuss that, I'm going to show you like how to do this CIPN to your, like if patient is complaining about CIPN in their fingers. So what we have to simply do, we have to first we have to set the machine accordingly to the what intensity, how much joule we have to fix it from the machine. Then ultimately we have to place this probe into their hand, and like this we have to apply it on their palm, and you have to continue it for 5 minutes. If they're having their problem in their palm, once you have to apply on your palm for 5 minutes, and then you have to move it to your finger. Okay. So this way, 10 minutes of this treatment has to be done. And after that, cryotherapy has to apply on their palm and the fingers. In the same way, if you have the problem in their feet also, so same way we have to apply it on their feet as well. So now the question comes how this PBM is going to help in this peripheral neuropathy, because it is such a big problem. So it ultimately, when any kind of peripheral neuropathy is happening, so we have to think from the cellular level. Like there is less cellular activity is happening, so mitochondria is getting suppressed. So the ATP production is getting lesser, and the nerve both growth factors which are there, it's become low. So this PBM, when we are applying this PBM, it increases the cytochrome C activity inside our cell. It boosts the ATP synthesis, and which is ultimately help in nerve repair and regeneration. It reduces the oxidative stress and inflammation in peripheral nerves, and it stimulates the neurotrophic factors, which is ultimately going to improve our nerve health. Now the cryotherapy, like how it helps, like when we are, when the medical oncologist or radiation oncologist, they are applying this chemotherapy to the patient. So it ultimately distributing to the whole body, and it's dividing the cells. So ultimately what happens when we are applying this cryotherapy, and we are applying it in -25 to -30 degree temperature. So that time, ultimately, what we are doing, we are vasoconstricting. So ultimately, blood is not going to reach in your extremities. So ultimately, when the blood is reaching less, so ultimately chemotherapy will reach less to your, like in the proximal regions like finger and the toes. So ultimately, when the chemotherapy will reach less, so it will give lesser problem of this tingling, numbness, pin rolling, and they have less pain and improve quality life. So now a very big problem comes in, like chemo brain. Like it's a cognitive changes in their brain. Like when the patient is having chemo brain, is nothing like they have the problem in their mood, like they have a lot of wrong thing comes in their mind, and sometimes they feel very fatigued and all. So here also rehabilitation play a crucial role, definitely along with the medical management. So like cognitive rehabilitation play a very important role in this. Cognitive behavioral therapy is the like that. We have to sit the patient in front of a monitor, and when we have to make the patient very relaxed, and we have to show them, like if you are not thinking anything wrong, how your like BP, pulse, every all your like vitals, how they're getting stabilized, and whenever you are thinking something wrong, and how this your vitals are getting up, like your pulse, your BP is getting high. So ultimately, we have to divert their patient thought, their emotion. They should not think much about their treatment. They should not think much about their disease, and somehow they have to engage their mind in some positive activities. They have to divert. They can do meditation. They can do devotional things. They can read books. So ultimately, they have to like not think, and like occupational therapists and neuropsychologists play a very important role in this. And fortunately, in our hospital, we have occupational therapists, so she can also manage this problem. And lifestyle change, we have to ask the patient for adequate sleep. And if the patient is complaining like in the daytime I sleep a lot and I cannot sleep properly in the night, so that time we have to somehow motivate the patient that she should not sleep much about in the daytime, and they should sleep more about, so that they can have more sleep in the night. And then exercise play a very important role in this, because when a patient is having any kind of problem, first thing which they avoid, that is exercise. There is a thinking that exercise will make me fatigue, but we have to make the patient understand that according to your body, you have to do your exercise. That's why we are again and again saying it should be tailor made. It's not like that we have to give a chart, this you follow. The chart is not same for everybody, because everyone is different. I am different, you are different. So everyone, according to their BMI, according to their physical state, according to their mental state, they have to change this exercises. There are like proper diet has to be there. A healthy, nutritious diet has to be there. We should motivate the patient. If they're not willing to have food in one shot, we have to motivate the patient. You take a nutritious diet and take it in a smaller break. You go much many times you can have. In every 2 hours you can have some food. So like this problem, this has to be also discussed, like oral mucositis. Like before few days, like when Hina Khan was like diagnosed with breast cancer, even Sonali Bendre, when they got affected by this breast cancer, in the Instagram they used to post like we have difficulty in swallowing the foods. How it's going to happen? So ultimately, when chemotherapy is being delivered to the patient, as it's break all the cells in our like body, it even affect in our this oral mucosa also. There also it breaks the cell, and there the inflammation comes in. So and the swelling also come, and along with that the patient have like a problem of dryness of mouth even. So dryness of mouth and this breakdown of oral mucosa both can lead to like then this oral mucositis. And here like again I will say this photobiomodulation play a very important role in this oral mucositis management. And before photobiomodulation, like these are the ultimate treatment. Like before, we have to ask the patient for frequent oral rinses. Better to do like 1 teaspoon salt, 1 teaspoon baking soda in 1 liter, and do a benzodiazepine mouthwash, and do your oral rinse at least 8-10 times in a single day. And we have to ask the patient for a soft diet, and not to have too much hot food. And along with that, we can suggest the patient to have keep ice chips in their mouth. It also ultimately gives them a lot of relief. So like here at the photobiomodulation therapy techniques, how it helps in the like oral mucositis. It's the power, you can see the previous slides I have shown the power. It was 4 to 6 joule but per centimeter square, but here the power is less. It's 2 to 6 centimeter per centimeter, and power is also less. It's 50 to 200 milliwatt, and treatment has to be 30 to 60 seconds per lesion. And application should be directly on the cheek or your tongue. Wherever you have the problem, you can apply this photobiomodulation. So again, if you want to see how it's going to apply, again you have to set the machine and you have to apply it on your neck or your cheek, and then you have to apply this in this way. And particularly if you anyone have any particularly any smaller mucositis on their tongue or lip, so that time we can use this intraoral probe. We have to check wherever they have the problem. We have to open the mouth. This we have to insert, and we can apply in this way. Every single point we have to use it for 30 to 60 seconds according to the severity. So like the question come, how this chemotherapy can cause the hair loss in breast cancer patient. So it's a very common problem in the breast patient. So ultimately, when it's dividing the whole cells of the body, it ultimately break the cells in the hair follicles also. So in this way, first when they start the treatment, they have the direct effect on their hair follicles. It like first they have the hair thinning. Day one, it's not like their hair will fall. First, the like hair thinning they will suffer. Then there will be hair breakage, and ultimately it will cause complete hair loss. So like inflammatory damage also happen to the scalp, and increased oxidative stress also there. Like there is vascular disruption will be there. So these are the phases in which the hair will fall. On the first 1 to 3 weeks after the chemo, it will start. It's not like day one it will start. Maybe after 1 to 3 weeks, your hair thinning will start. Along with the as your cycles, chemo cycles are getting, the peak hair loss will be on the first to 2 months into the treatment. And when your chemotherapy finish, then after the 1 to 3 months, your like yes, when you stop your chemo, it's like the regrowth begins, and after 6 to 12 months your full hair recovery will be there. So what are the prevention and treatment strategy for this hair fall? There are two modalities we can use. One is scalp pulling therapy. It ultimately reduces the blood flow to the hair follicle, so that it limits the chemotherapy exposure to the hair follicles, and ultimately it reduces the hair follicle um, hair fall, and up to 50 to 75% less hair fall will be there. In the same way, the photobiomodulation of the low level laser therapy can help in hair fall. So how it work in a different way? It increases the follicular repair, and it reduces the inflammation and promotes the regrowth. And recently, very recently, last year in the month of November, it got a FDA clearance for this treatment for this hair fall. And nutritional support is also very important, so that for the keratin repairment, nutrition supplements is very important. Now we will discuss a little bit of silicone breast prosthesis, which is also less discussed, because when you understand, like when a patient is having a mastectomy, it may be radical mastectomy or complete mastectomy, but why they need this? Not only for the prosthetic purpose we have to use this, but you have to understand like their body alignment has go wrong when they have this mastectomy. So ultimately, unknowingly, they have to safeguard. Suppose one side their right side their breast is there and left side they don't have. So ultimately, to compensate that weight, so what they ultimately slowly their posture getting like this. So ultimately, they have a severe pain in their upper dorsal region. To prevent that posture disalignment, we have to suggest this breast prosthesis. And along with that, this give you a, like for the cosmetic purpose also it will be solved, and it will patient will be more confident, because when the patient first it comes into their mind like how I will look. So look wise also she will be in a more benefit. So it ultimately restore the body symmetry and balance. It improves the self-image and confidence. Sometimes like it's a very good option for the reconstructive surgery. One thing is that everyone cannot afford the reconstructive surgery, and everyone is not suggestive for the reconstructive surgery. So that's why they can use the silicone breast, and like it's very comfortable and it's very realistic. You can use it anytime. like after the surgery, your healing is over, you can use this breast prosthesis. And it's look very similar to your breast according to your size. It comes like this. It comes inside a pouch so that you can remove your pouch at the night time, and you can wear inside your brazier so that you have more confidence in you. You have less fear to go to the society. These things are very, very important. And ultimately, it like prevent the shoulder drop even. Like they have a complaint of like this, they should not do sit like this when they have this. Ultimately, they will have cervical pain with radiculopathy. So it all ultimately helps in. So that's all. It's like we will say like cure is not the end. Care is a continuum, and the focusing of the quality life ensure the breast care survivors. So with this note, I'm just going to finish my talk. So breast care doesn't end with the last chemo. No one can say this is the last chemo or this is your final surgery. It continues in how our patients move, how they work, they love, and they live. So rehabilitation is not just an add-on; it's a vital bridge to a meaningful recovery. So let's make this bridge together. Thank you.
Uh, that was a wonderful talk, Dr. Dibyendu sir. Like it was a very elaborative presentation, giving basic insights of the rehabilitation process which you all follow. It was a very wonderful talk to hear.
Thank
Uh, I would like Dr. Gaurav sir, if you wish to add something to the talk.
Yes, once again, it's been a very wonderful session. And even though there are not many senior consultants or practicing physicians attending this webinar, I would like to request the trainees, the PGTs, and other fellow physicians to kindly this entire session will be available on Facebook through our channel. So what I would request is that you must please save this video. There is a ton of helpful nuggets within this in this entire 1 hour session. It's been put very beautifully. There are plenty of tidbits here and there, and these helps us in managing our patients day to day, whether they are patients with oral mucositis, whether it is trismus, whether it is lymphedema due to pelvic malignancies, or whether it is a breast cancer patient suffering from lymphedema. So what I feel is that this is not a question of that whether there will be questions on this topic at all. Yes, you will be getting questions. You will be getting questions such as lymphedema in case of breast cancer patients. You will be getting questions such as trismus. You will be getting questions in your fourth paper, like regarding the advanced, what you call the recent advances. You might get a few couple of topics, but what I want to suggest that this session is beyond your exams. It goes throughout your life, throughout your practice. And this is what I want to kind of emphasize from all of you, that you must kind of save and tag this video so that you can keep coming back to this video time and again, and keep revising, like whether you're seeing any patient, whether it is a abdominal malignancy, extremity malignancy, patient who's having chemotherapy associated alopecia. So I think it's very essential that it's not only, even though the main purpose and the intent of our Onco Ocean was to help the PGTs prepared to have a compendium, to have a kind of a bank where they can keep coming back and prepare the questions, have the topics related, starting the basics and very much exam oriented. But this 1 hour, it is going to be much more than that. I'm really grateful for Dr. Dibyendu for presenting the topic so lucidly. And I feel that this is going to be a treasure trove for physicians, for clinicians, for students alike. And I really thank Dr. Aditya and for Apex Hospital for organizing this kind of this weekly session, of which each of the sessions are by themselves, they are gems. And I think that this is a wonderful kind of opportunity to learn more and more. And the students and the PGTs who have been able to join us in the last 1 hour. And it's been really wonderful. And good night to all of you. Thank you.
Thank you.
So, so far there are no questions in the chat box. Like all the participants, like if you have any queries, can post. We can wait for some like 5 minutes more. Like if you all have any questions to answer them. So as sir has said, all the videos of the OncoOceans are always available on Facebook and on YouTube channel. Whenever any participant or any PGT wishes to see them again, we have made them available on the offline mode also. So like it is advised to them that they can follow it on the YouTube channel. And I don't see any questions here. So I would
Yeah,
like
because this is relatively a very new topic, and it's better that the students pay more attention rather than asking questions. But again, as I said, that it's better that they keep coming back to this video. And I think Dr. Dibyendu can probably share his email in the kind of the chat box, so that if the students, if they find something which is new and they need some more clarification, probably they can uh, sort of email him personally, or also they can always put it in the chat in the YouTube channel. But I think it's better that rather they can approach him personally if they need some clarification, and maybe he can help them out, even even if it kind of relates to the exams. If they need any latest updates, any new topics, I think that would be helpful.
So as we come to the end of this session, I would like to thank our chairperson, Dr. Gaurav sir, and our speaker, Dr. Dibyendu sir, for this wonderful session today. Thank you, sir.
Thank you. Thank you.
Thank you, everyone.
And on this note, I would like to close today's session. We will be meeting on next Wednesday with a new topic. So stay tuned.